Hello, good evening, students. I am your mentor, Dr. Ruchi Raj, and today we are live on YouTube to discuss the most important topics of prosthodontics for the upcoming INI-CET exam in November 2024. I am Dr. Ruchi. I completed my MDS in Prostho from AIMS New Delhi, and we have discussed several different seminars and topics on this platform. In case you're watching me here for the first time, hello. Please put down any queries in the chat box down below. I'll be happy to solve them. I'm simultaneously checking all of your comments or queries on YouTube chat box also. And today's session now, it's titled Most Important Topics of Prostho. And what is the purpose of today's session? Can we teach you all maybe very important topics of Prostho in the next 1 hour? It is difficult. We have covered the entire syllabus in 35 hours, revision in about 8 hours, and now we have 1 hour ahead of it. So, how can we make the most of it? See, students, all of those topics that just need to be memorized, we will not be touching upon today. That does not mean that they are not important. But today, I will try to teach you some core concepts of Prostho. If you have seen my videos, you would have understood them better till now. This will be a revision for you. I'll try to teach you those core concepts that are interconnected to a lot of questions. And since we are talking about most important topics for INI-CET, just a few days back on YouTube only, I discussed 5 smart ways to prepare for INI, where I said that INI CET focuses on case based questions and clinical concept based questions. So, these 5 to 6 different concepts that I'm trying to teach you right now, they will help you answer these questions better. Right? So, let us begin without wasting any further time. First and foremost, now, what I need to explain to you is that, see, Prostho for INI-CET 2024 November, right? What we are planning to prepare and how we plan to prepare. All concept-based questions generally, or tougher questions generally, will be from CD and RPD primarily. Now, everything that needs memorization, that will be primarily from FPD, and some new questions can be expected from implants or even maxillofacial. Now you can expect images quite often from implants and even numericals from implants. This is just a broad division. Now, although I've written this over here, my core preparation for this exam. By what do I mean by core preparation? For example, I'm expecting 5 to 6 questions of Prostho in INI-CET or maybe 10 questions. If someone would say that, can you predict the 7, 8 questions out of those 10? I will tell you with surety those questions will be coming from this section mainly, right? Those, that is for sure, it comes from those sections. So the smart way to crack these exams is, rather than running after implants or things that are coming new and getting worried about it, target the core questions and answer them perfectly well. So concept based questions, CD, RPD primarily, and then the next of it. So that is why I'm teaching you these concepts again, so that you don't fail on those questions in the exam. This is just an analysis in the past 5 years papers that I have done. With implants, it's like a googly that comes in exam. Anything can come. So if I were a student, what I'll do, I'll target the basics, what has been asked till now, and I have taught you all of that in my either previous year questions or in revisions or in the videos. That much I'll target. Same for maxillofacial also. Then I will probably see, if implant something new is coming, it is new for everyone, so everyone might lose a mark over there, so it does not matter. So what I'll try to cash in is my CD and RPD questions, because that is where I expect that something new can come. It could be from the same topic zone only, but the question can be formatted and changed for you. Right? So about 20-25 students are watching. Hello, good evening everyone. Are you all preparing well for IICT? If yes, just comment a thumbs up or hello in the chat box. So we'll keep the session very lively over here, right? I don't want to keep it very dense for you. I will keep the session very lively. So all 20-25 students that are watching, can we get a little thumbs up? Hello, good evening. How is your preparation going? Don't be worried, right? Everything will fall in place. Just don't be worried. Everything should be fine. So this is just the basic of it. Now, the first thing that I want to teach here with you, and I'll tell one more thing to our students, that yes, Aparajita, Anand, Ruth Merlin, Kirti Gupta, Dipayan, Pranjal, Sachin, Aparajita, Dipayan, Akshita, Smita, Tanvi, TXYDU, all of you, very good evening, right? No, we are not giving knowledge and time for free. It's not like that. It's taking your time, which is the most important currency. So I should use it very well, right? So if I'm taking up your time, you should learn something out of it. Now, the first concept which I've seen students keep asking me again and again, what is the interrelationship? See, main part of this video for the next, I think 15-20 minutes will encircle around occlusion. I won't even say jaw relation, I'll say occlusion, because that is where you don't view it as an interrelationship, you view it. So Facebow and vertical dimension, what is the interrelationship of it? And why is it so that a lot of students feel that if vertical dimension is being changed, then why do we record Facebook for it and why do we need? Do you all feel like that? That if vertical dimension, there's some disturbance in the voice, students? Are you able to hear me clearly? Aparajita is saying that there's some disturbance in the voice. Other students' voice is breaking at times. Move in closer a little bit. Is it fine now? I think there was some disconnection for a split second, so that would have caused the disturbance. Is it fine now, students? I think it is fine. It's still there, the disturbance is still there. The disturbance is still there. Is it still breaking? Okay, just a second. I can see from my end it's going pretty fine, but okay, I'll try to be as close as possible so that the voice does not break. Fine. Now the interrelationship of Facebow and vertical dimension. Now it's okay, students? I think now it's okay because now audible. Yes, a lot of students are saying. So sorry for the technical issues. It does happen sometimes here and there. What can we say? So the interrelationship of Facebow and vertical dimension. Now a lot of students feel that when we are recording for a patient, then why is it so that we need to record Facebook? So, what is the relationship over there? Let's come up to this particular point. I've shown this to you in a video also ahead. Now, check out all of the definitions of Facebook or orientation jaw relation or whatever you have learned till now and just focus on one thing. When we do jaw relations, we are trying to orient three-dimensionally how maxilla and mandible are related to each other in a static as well as dynamic way. Static way means what is the intercustation between both of them. Dynamic way means how is the mandible closing and what could be the path of the mandible. Now, how does that affect? When the mandible opens and closes, there's a particular path and there's a particular pattern in which the teeth will meet. That means a particular cusp will touch first, second, some other cusp tip will touch. All of that will affect the occlusal contact points of a restoration. Do you all agree with me that much? That this is the static and the dynamic part of an occlusion that your jaw relation is trying to capture. Agreed, all of you? This much you have understood, students? Fine. So I think that is something that you would have understood. So now what happens is that there is a particular hinge axis here along which the mandible opens and closes like this, right? There's this actually, this is a video only, but I don't know why OneNote is not opening it as a video. Otherwise, it beautifully shows the mandible opening and closing like this. So, when the hinge axis opens and closes, there's a particular way along which the mandible opens and closes, and it is how the teeth over here would intercuspate. What will Facebow do is that it is trying to find that axis and transfer it on the articulator here. So your articulator will also maybe simulate that opening and closing movement of mandible. Now, this much you understood that we have simulated and transferred this hinge axis on the articulator. I think a lot of students who have done these sessions with me till now would have been knowing this concept. I'm sure a lot of my own students would be knowing this concept. This much you would be knowing. But there's a next question that I'm asking you. By doing this, what benefit does it give us? What is the purpose of all of this? The benefit it gives us is that when we are fabricating a restoration, for example, I am making a crown on this particular posterior, all of these posterior, then how the occlusal surface anatomy of those crowns will be, and how the contact points will be, and how they will come in intercuspation with the opposing arch on the articulator will be similar to the mouth if we have recorded a current hinge axis. If your hinge axis is accurate or it is close to the actual hinge axis, then how these occlusal contact points are present in the oral cavity in the patient's mouth dynamically, similar patterns would be there on articulator. Again, a question, how does that help me? It helps you to save chair side time, because a static relationship, that means just intercuspation of teeth, cannot help you identify what is the correct occlusion, because दो दांत ऐसे मिल रहे हैं but ऐसे आके मिल रहे हैं, ऐसे आके मिल रहे हैं, कैसे मिल रहे हैं दांत, that will determine where the first contact points occur. And if you don't know that, what happens in chair side in the patient's mouth is you are grinding because there will be very weird high points coming into your crowns in the patient's mouth. But if your hinge axis has been recorded, the Facebow hinge axis has been recorded and transferred to the articulator, what happens is that you would be able to simulate all of these closure patterns on the articulator only. So your restorations, how they are in the articulator, it will be similar in mouth only, and you will have lesser occlusal discrepancy. In a way, you will save your chair side time. You will have your precious occlusal anatomy that you have created on the crowns preserved in the patient's mouth. That is the ultimate goal of this recording of hinge axis. Now, when we are doing multiple posterior restorations, that means all posteriors are missing. When we are doing full mouth rehabilitations, when we are doing TMJ disorders treatment, all of that which requires reorganizing of occlusion, or when we don't have any centric stop, all of those situations will require a Facebow transfer. Now, coming to our bigger question is that, but when we are changing vertical dimension, why do we need a Facebow record? The reason is that this hinge axis, opening and closing of mandible, is accurate for a particular vertical dimension only. And every change in few millimeters of vertical dimension will change that rotational axis, because actually every vertical has a new centric also. So because of that, you need that record. Secondly, all of your semi-adjustable articulators are made in such a way that there is a adjustable incisal guide pin. So when your question says that we are changing or altering vertical dimension and raising the pin by 2 millimeters, then if you have made a Facebow record, you are allowed to change that directly on the articulator. You don't need to make new records. That is allowed. That is written in the manual of these articulators, which means when I have a semi-adjustable articulator, right? Should I write it down for you? I think that's too much of information, so I'll write it down. When I have a semi-adjustable articulator, right? And there is an incisal pin like this. And on the articulator, I want to raise the vertical dimension because I want to similarly raise that vertical dimension in the patient's mouth. You can raise it by 2 millimeters if you have made Facebow records. And similarly, when you want to change vertical dimension of a patient, you need these Facebow records because you're reprogramming the entire occlusion. So this is the entire concept around Facebow and vertical dimension. Till date, I think once in every 2-3 days, I get this doubt in any of our groups that when we are changing the vertical dimension, why is it so that interocclusal records are not necessary and kinematic Facebow record is necessary? The reason is this, that you need to record your hinge axis accurately if you want to change the vertical dimension of the patient because we are reorganizing the occlusion. Obviously, during the process of it, you need interocclusal records, but the most important record over there is your Facebow record. So, students, this is the first concept, which is the interrelationship of this Facebow and BD. Have you all understood this? Give me a yes, no, maybe, confused even more. If confused, go back to the video again, maybe at 0.75x or 1x, and slowly try to understand it. But I've poured everything down about Facebook and BD in this past 5-10 minutes. Students, understood? A lot of students have joined in. I hope you all have understood. Yes, there are some yeses from our students, so it's good to go. Right? So this now where it will help you. It will help you in CD, it will help you in RPD, it will help you in occlusion questions. It will help you solve all questions around Facebook. And trust me, questions come from Facebook. Definitely questions come from Facebook. That is why you should be knowing this concept. Now, second, again, this photo, I think a lot of students would may be able to recollect it from if you have attended any classes of mine. So, what exactly vertical dimension is? Vertical dimension at rest position is the distance between this tip of the nose and say the tip of your chin, the most prominent point on your faces right now in the rest position that you are sitting. All of you are sitting in rest position. If I measure this distance, that is VDR. That distance is called as vertical dimension at rest position, right? That is, now remember this and mark my words over here. VDR is something that we measure from a patient. We are just measuring it. We won't be able to alter this in a patient. We will just be able to measure this, right? But VDO is something that we establish. Again, a good concept over here. Now, all of you students sitting right now, swallow and close your mouth. When you swallow and close, your mandible goes up, right? So there was some gap between your teeth and your mandible has gone up. Now, when I ask you to intercuspate or close your mouth, the gap, or I should say the distance between the tip of the nose and the tip of the chin is called as vertical dimension of occlusion. We as dentists or prosthodontists establish this VDO, vertical dimension of occlusion. And the gap you saw between both of them, that is freeway space, which we need to establish in every case and give it 2 to 4 millimeters. So VDR is something that is always there in a patient. We are just measuring it with different techniques. VDO is something that we establish. For example, if I measure between these 2 points at one instance and it comes as 64 millimeters, it is my job to establish the VDO at 62 or 61 so that I keep a freeway space of 3 millimeters. So that is the concept of VDR and VDO. Understood, everyone? Quickly give me okay, yeses in the comment box. Students, just give me okay, hello. Hello, students. Give me okay, thumbs ups. Fine. So this is VDR and this is VDO and this concept. Now, the questions that come from here are regarding increase and decrease in vertical dimension. What, when they say increase VD or increase vertical dimension, they are trying to tell you that VDO has increased. And when we write decrease vertical dimension, we are saying that VDO has decreased. When VDO is increased, freeway space will decrease. Here, freeway space will increase. Now, the most prominent feature of increased VDO is what, students? Is clicking. Teeth will start to click. Now, why do they click? Because there is no freeway space. So, both teeth are continuously meeting each other and they'll start to click. The most prominent feature of decrease vertical dimension of occlusion and increase in the freeway space is angular cheilitis. Just remember these two at least because they are commonly asked as questions in your exam. So that is about vertical dimension, VDO, VDR and your freeway spaces. Understood this much, students? Fine. Shall we move ahead? It is almost halfway through the session. Shall we move ahead? All of you are able to understand what I'm saying, or is this helpful? Is there any particular topic or a doubt that you want me to explain? Please put it in the chat box. I'll take it up. Angular cheilitis and Perleaf clinically are same, but the nomenclature is different. Angular cheilitis and Perleaf is due to nutritional deficiencies. So we use that terminology for whatever problems that occur at the corner of the mouth because of nutritional deficiencies. But if your say question uses it interchangeably, you can select it as the option. Ideally, it should not be used interchangeably. Right? So two very important concepts from jaw relation. I will even teach you the third one also. Right? Now, the third very important concept, because again, this comes in the exam in different forms in RPD questions. Centric relation, centric occlusion, and maximum intercuspation. Yes, Aparajita, I understand. In some questions, it would be given maybe. Whosoever has set the paper might use it interchangeably. If you understand the meaning and if you know that this is what the examiner is intending to, you can select that as the correct option. Now, again, explaining you very good concept of CR, CO, and MIP, and how it relates to complete denture occlusion. And then we'll discuss slightly about different occlusion schemes also. Right now, it's relation, what exactly it is. We'll go back to our picture. See this relationship of the fossa to mandible. Yes, Kirti, I'll just get back to you about group function and canal guided occlusion. I'll definitely take it up towards the end of the session. Now, what is centric relation? First, let us try and understand that. We have condyle and a fossa. Now, the definition of centric relation says that it is the maxillomandibular relationship in which condyles articulate with the thinnest avascular portion of the respective disc, with the complex in the anterior-superior position. So, thinnest avascular portion of the articular disc and the complex is in anterior-superior position. The main thing that what I want to teach you here is that centric relation is a bone to bone relationship. It is the relationship of condyle with the glenoid fossa. Why is CR so important for complete dentures? It is the only relationship which is musculoskeletally stable and reproducible. By reproducible, I mean if I ask you to reproduce the same position again and again, you should be able to do that. In a complete denture patient where there are no teeth stops or intercuspidary stops, CR is the only reproducible position. So remember, centric relation, bone-to-bone relationship where condyles articulate with the thinnest avascular portion of the disc, the entire complex in the anterior-superior position. That is called centric relationship. It is the only relationship where the entire complex is in a situation where all the muscles are in a stable, unstrained position. Right? That is CR. Now, what is CO or centric occlusion? I can say that when this situation is present at the bone level, whatever intercuspation is between teeth, whatever occlusion or intercuspation is present between the teeth, when the condyle is in CR position, is called centric occlusion. Whatever is the intercuspation between the teeth, that is called a centric occlusion. And what is MIP? Maximum intercuspation or MIP has no relevance to both of them. MIP is simply any position where maximum teeth intercuspate. It has no relationship to what is the position of the condyles here, right? Now, in a complete denture patient, what we do is, since we do not have an intercuspatory stop, now for all of you, I'll give you one exercise also. Take your tongue to the most posterior part of your palate right now. All of you do that. Take the tongue to the most posterior part of the palate and very gently close your mouth. The first point of contact that is happening between your teeth, you are in CR position. From that point of contact, there will be a touch, and you might slide your mandible anteriorly and then close into your maximum intercuspation. Do you all agree with me? That happened with you? Do you agree that you tried and that happened with you? It will be there in majority of the patients. This discrepancy that is present between centric occlusion, which was your first point of contact, and the maximum intercuspal position in dentulous patients is fine. Reason is that we have teeth as guide for us, the intercuspations as guide for us to close, and also we have different proprioceptions also in the teeth. But for a complete denture patient where there are no proprioceptors, you cannot have this touch and slide because they don't have any guide like that. So for edentulous patients, what we do is we will rehabilitate the patient in such a way that maximum intercuspation should be in CR position only, which essentially means that MIP is equal to CO. Understood this much? So that there is no discrepancy of this 0.5 to 1 millimeters and MIP is equal to CO. Now, canine guided and group function, what exactly it is. When we talk about occlusal schemes, occlusal schemes basically, now this is no textbook uh, classifications or anything, something that will be pertaining to centric and something that will be pertaining to laterotrusive, or should I say eccentric movements. So something that will define how the centric relationship is and something that will define how the laterotrusive relationship will be. Now, your canine guided and group function basically is explaining this eccentric relationship. What happens is that in a young patient generally, the canine has a very long root. It has very good proprioceptors. So when we take the mandible to the right side, for example, all of you can try and do that with me. We are keeping the mouth closed only, but keeping the teeth in contact. I'll try to take the mandible to my right side till the lateral teeth are in contact. In that situation, supposedly, only if the tip of the canines are in contact like this, and all of the other teeth are disoccluded, that is called as a canine guided relationship. Now, why does that happen? See, the core concept of occlusion and its forces is that centric forces or vertical forces are very well borne by posterior teeth. So all of the centric contacts are taken up by posterior teeth and anteriors are generally out of contact. But when you open your mouth or keep trying to close it, and when we move laterally, at that time, the posteriors are out of occlusion so that there are no lateral stresses onto it. Now, if the canine is keeping them out of occlusion, it will be called canine guided occlusion like this. Over a period of time, it may happen. Canine may be weak, periodontally unstable, or maybe the tip of the canine has worn off. In that situation, what starts to happen is the buccal surfaces of all posterior teeth start coming in contact. When that happens, since all of the teeth are coming in contact in a group, that is called as a group function occlusion. So, Kirti, I think that solves your doubt. That is canine guided and group function. Canine guided is naturally present in young individuals. Towards middle age, we transition to group function occlusion. If it is on one side, it is unilateral group function, right? Something like that. So I think, Kirti, that solves your doubt. Now we have discussed quite a lot around occlusion. We've understood the interrelationship of Facebow and VD. We've understood what CRCO MIP is. We've also understood things around vertical dimension. These are areas from which questions come very frequently. Now, another area which I feel a lot of students might have doubt: direct retainer choice in distal extension scenario. Are you all confident with this particular part of RPD? What is the direct retainer choice in a distal extension scenario? Are you able to understand that? Give me a yes, no, maybe, confused. Are you able to follow and understand this particular section of RPD? Can we sure I'll try to explain Possel's figure if time permits towards the end of the session. Okay, so Aparajita is saying that yes, it is confusing and you might face some issues with it. Now, why direct retainer situation in distal extension is difficult or is confusing? So, all of those students who are saying no or confusing, in the next 10 minutes, you will be able to solve this. Keep that much trust on me. Fine. And if you're able to solve this, you do let me know. Right? So, direct retainer in distal extension situation. Why is this area so complicated? And what is the problem here? Chalo, let us try and draw here. Actually, for some reasons, OneNote is showing my figures in a very blurry manner. So I'll personally now try to draw it out only for you. So direct retainers in distal extension, right? Now, before we move on to distal extension, we'll see the normal stuff. Suppose two molars like this, and say for example, okay, one premolar, one molar, and maybe 1 to 2 teeth are missing here. What Kennedy classification would this be? This is a tooth supported case. So Kennedy class 3. Right. Now in a general tooth supported case, the placement of occlusal rest is what? Adjacent to edentulous area. Generally, in any circumferential clasp, these are very important words and terminologies. So try and remember that. In any tooth supported case, right? In any tooth supported case, a circumferential clasp, the rest is situated adjacent to edentulous area. Or rest is rather placed adjacent to edentulous area, and undercut which we engage is generally away from edentulous area, right? So with that logic, this is where the rest would be, and this is where we are engaging our undercut. That is our choice. We are doing this by our choice. The reason is that when you have this particular, see, start imagining the retainer like a hook like this, and see what direction the forces would be. This will be the direction of force. This will be the direction of force. When they engage the undercut, these are the directions of forces. I'm exaggerating and drawing it out for you, but these will be the direction of forces. They will be nullified against each other because they would be same in magnitude and opposite in direction. So in a tooth supported case, it becomes very simple. There will not be any issue. But what happens in a distal extension case? When you have a distal extension like this, fine. Students, are you able to understand what I'm drawing? If I go by the same concept of rest adjacent to dentulous space, undercut away from the dentulous space, the direction of force will be this. And what happens? The tooth will start to move into the edentulous space. Reason is it has no counterpart over here. Do you all agree with me, students? Yes, no, yes, I think yes, you all should agree with me. Right? So this is the reason that a simple circlet clasp has these rules. These are the rules which I've written in green above for a simple circlet clasp. Cannot be used in a distal extension because of the unbalanced orthodontic forces that will be generated. Eventually, your abutment will start tipping into the edentulous space. So, what is the solution for it? What are now the solutions? Let us understand. We'll try to draw the same thing. Fine. First solution is engaging this undercut. So, when you engage this undercut, what clasp is it called, students? Tell me. What clasp is this? Same, same C clasp. But we have done the reverse. The rest is placed on the mesial side. Abutment undercut we are engaging is on the distal side over here, right? So when the forces will be generated, they will be in this direction, which will be very well tolerated by the proximal tooth at this point. What clasp is this? Students, quickly start typing in the chat box. What clasp is this? Yes, very good. So this is reverse circlet clasp. So first choice is reverse circlet clasp. Whenever possible, you can utilize this clasp. Or go for infrabulge clasp. Infrabulge clasps are what? They usually engage the mid buccal area. right? And again, they have occlusal rest at the mesial position. So you can go for infrabulge clasps. Specifically, you can go for RPI systems. So these are your choices of clasps in distal extension case. Do not get confused randomly. If you remember this particular line in green, you will never be confused. Remember, there is no mesial distal. There is adjacent to edentulous area and away from edentulous area when we talk about C clasps. I hope that much is clear. So direct retainer choices in distal extension case. Now tell me, Aditi, Aparajita, and all other students who said it was confusing. Is it clear for you now? Would you be able to solve these questions now? Yes. Yes, so Aditi, Aparajita, and I hope a lot of other students are saying yes over here. Riddhiman, excellent. So I'm happy to see that there is at least some benefit and you're gaining something out of it. Now, coming back to something again from occlusion, but a very good diagram for you to understand. You must have seen the five elements of balanced occlusion: incisal guidance, condylar guidance, compensating curves, plane of occlusion, and cuspal angulation. And that is how balancing is present. See, balancing is basically what? Balancing essentially is that so let's see, where will we use RPI? All of those teeth that fall in the aesthetic zone. That means premolars, canines, and then all of those we will use RPI because they are aesthetic clasp. Reverse circlet specifically is used in those situations where you cannot use infrabulge clasp. Matlab, any soft tissue undercut is present or this gingival sulcus height inside sulcus height is not enough because as you know for RPI or for a bar clasp you need particular height for minor connector. If that is not enough, you can go for reverse circlet clasp. Yes, combination clasp is also given. Definitely, combination clasp is also used. So all of these are good options for distal extension. Now coming back to balancing. What essentially balancing is. Now, when I teach retention stability support, all of you, have you checked out the video basics of prosthodontics? It is, I think, a 10-15 minute video. And tell me yes or no. Have you seen that video? If not, I'll tell you, see that video once at least a week. So retention stability support is embedded in your mind. Right? So that particular video, I have explained that the single most important factor for occlusion, for stability is occlusion. Reason is that what essentially stability is, for example, you are sitting on a chair right now. I chop off 1 inch of one of the legs of that chair. The chair starts rocking like this. I say lateral movements and the chair starts rocking. Similarly, when your denture starts rocking, it loses stability. And this rocking happens because of what reasons? Not because of vertical forces of occlusion, mastication, all of that, swallowing. No, it happens because of lateral forces. What are lateral forces? Forces of cheek and force of the tongue. So that lateral forces leads to loss of stability. Now, lateral forces, how are they generated? Do you all know how lateral forces are generated? If, for example, if two arches are meeting like this and there is only one pointy tooth that is coming in contact and not allowing other teeth coming in contact, it will cause, when the teeth will meet like this, it will cause a deflection and then the mandible might deflect and then close. These are called occlusal interferences. I'm teaching you in very layman and basic terms, but that is essentially what occlusal interference are. That when both arches are meeting, if the occlusion is very settled and harmonious, they will fit into each other very easily. But if there are pinpoint heavy contacts or high contacts, they will act like these tips that meet and then deflect the mandible, and then the mandible takes a slightly different route and closes the mouth. These are called occlusal interference. And every time this deflection happens, it creates lateral forces. So these lateral forces leads to loss of stability. And balancing is essentially what? Balancing is the contact of both maxillary and mandibular teeth in all of these planes, in all of the movement. So ना रहेगा pinpoint contact, ना रहेगा lateral stress, and you will have simultaneous seamless movement in all planes. Essentially, both of the arches move in sync with each other. Absolutely no generation of lateral stresses theoretically, and you have perfect stability, and hence that is the role of balancing, right? Now, to achieve this theoretical balancing, I'll tell you theoretical only because practically very difficult to give in a patient. It is a mathematical equation that I'm showing you. I've brought this from the textbook of occlusion. It is not there in our CD textbooks. It's theoretical only. See, in this patient, for example, this here is incisal guidance, this here is condylar guidance, and this here is cusp angle. Mathematically, if all three angles are of the same value, then they will glide against each other. If this is 30 degree, this cusp angle is 10 degree, and incisal guide angle is say 20 degree, they will not glide against each other because the planes are at different angle. The plane, all three planes, if they are at the same angle, only then they will glide. See, if they are at the same angle, only then the mandible and maxilla can glide against each other. So that is how you gain balancing. When condylar guidance, incisal guidance, and cusp inclination are related like this. Now, why do I teach you over here? I'll teach you this why. In your exams, questions come as say incisal guidance value is cusp angle is say 30 degrees, then what should I do to correct it? Should I increase the value of incisal guidance? What should I do? Or two three other options. The correct answer here is to increase the value of incisal guidance, because if cusp angle is changing, then incisal guidance should become steep. For example, another question is saying that cusp angle are you're making them slightly flatter. So to compensate that, what should you do? You should reduce the incisal guidance. We cannot change the condylar guidance value. So the interrelationship of condylar guidance, incisal guidance, and cusp angle is this mathematical equation over here, which is actually changed in different concept or case-based questions and given to you as a question. But I hope now I think you would be able to solve that. So I think this portion should be clear for you, students. So we learned quite a lot of occlusion concepts actually. We learned about balancing, vertical dimension, Facebow, concept around centric occlusion, and yes, Siemens formula is also related to this, but this is also how balancing is primarily related to each other. Now, that is also something that we saw. We saw about direct retainer situation. So now, after that, we have about 10 minutes remaining. There's a newfound question that I see students having quite a lot of confusion. See, I'm not touching on topic from implant. I'll tell you why. A lot of numerical questions are there for implants, distance between teeth and implant, distance between two implants, and all of that, which I've already covered in my videos a lot of time. There's no point giving you topics that are memory based topics, which you can even see notes or videos and learn from there. Point here is that I want to teach you conceptual things that I have seen students ask me doubts very frequently. So we've learned all of these concepts. That is why I've not taken much from FPD also here, because I consider FPD is very theoretical only. But that does not mean it is not important. See, from FPD on last days also, revise Pontics, finish lines, right? Pontics, finish lines, shade selection. At least revise this much. And all astringents. Astringents, I think you all have made that table with me through our notes only. So you can just revise that. All of these are memory based topics. You need to mug them up. So that is why I'm not covering it here. Now I take one small portion from maxillofacial prosthesis, which I feel that a lot of students may not understand that well. Is I think I don't know if I covered it last time also. Velopharyngeal defects. Don't remember. Velopharyngeal insufficiency and velopharyngeal incompetence. I think I covered it for our students last time, but still it will be revision for it. Now, velopharyngeal defects or soft palate defects. When we say insufficiency, we are talking about anatomical defects. That means there is some sort of cleft present. Incompetence means soft palate is drooping. It is not able to elevate itself. So maybe it's due to some neuromuscular disorder. It is drooping. It is not able to elevate itself. Since you have a cleft here, you need to obturate the cleft for insufficiency. So you give a speech bulb obturator. But for velopharyngeal incompetence, because the palate is incompetent to raise itself to the correct position, we give it a palatal lift prosthesis. Right? So that is from the maxillofacial portion. So that is all about all of the important concepts or topics that are there from Prostho. Remember, when you're preparing for INI-CET, you will receive a lot of conceptual questions in your exam. Of course, pattern keeps changing every sometimes, and this could be an exam where pattern also keeps changing, but we do prepare according to what we have seen in the last years. So with that now, it is almost 8:54. I hope today's session was helpful to all of you. Please just quickly let me know in the comment box. Was today's session helpful to all of you? Did you learn anything from today's session? And if yes, then I'll be happy that your 1 hour was utilized very well. Soft palate obturator for velopharyngeal insufficiency. Soft palate obturator is for velopharyngeal insufficiency. Yes. So I think a lot of students are giving me yeses. Today's session was helpful. As always, any queries, any doubts, any suggestions that you have for me, please always come back, put it in the chat box, try and contact us on Telegram or whatever source of medium we are connected. I wish you all the best for your upcoming exam. Prosto is easy. Don't get boggled by questions. Try to read the question well and understand what they are trying to ask you. Try and now cut down the revision in 1 to 2 days only. Go through the notes very well, and I'm sure you'll do very best in the exam. So, this is Dr. Ruchi. Good night to all of you and happy.